Ma'am, we are starting, ma'am.
Yes, sir.
So, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. So, the topic for today's webinar is intrauterine fetal demise. I welcome all the participants. I request them to post their queries in the chat box, if any, so that we can have a short Q&A session at the end of this presentation. Now it's time to introduce our invited speaker for the day, Dr. Abida Parveen, ma'am. Madam is currently the consultant obstetrician gynecologist, sonologist, infertility specialist, and certified laparoscopic surgeon. Madam is currently associated with Crescent Multicare Clinic and Nellai Multicare Clinic, Tirunelveli. Madam has presented papers in various conferences and published research articles in national and international journals. Madam has conducted many free health camps and given many health education for school and college students. Madam has received various awards for her service and credit. Madam has received awards like Seva Ratna Award, Mapo C Award, and Karpaga Virchagam Awards, Kamban Award, and Best Doctor Award from the Rotary Club of Tirunelveli. So, with this short introduction, the introduction is very short. Madam, I welcome you, ma'am. I'm handing the session to you for further proceedings, ma'am. Thank you, ma'am.
Thank you, sir. Thank you for such a nice introduction. Good evening, one and all. It gives me an immense pleasure to address my fellow gynecologists on the most important topic of intrauterine fetal death. Actually, it is disheartening not only for the patient but also to the doctors, because we feel very bad when we check the patients for whole 9 months and we hear of intrauterine fetal death. We feel very bad. So it is most important topic. Why it is important? Because though the fetus is dead, we have to evaluate the causes and you have to prevent that problem in the future pregnancy. Our management is going to differ when we know the cause of the intrauterine fetal demise. So what is actually intrauterine fetal death? It actually denotes death of the fetus in uterus weighing more than 500 grams or more after 24 weeks before the onset of labor. If it is less than 20 to 24 weeks, if it is less than 500 grams, we label it as missed abortion. Incidence is 4.5 per 1,000 live births. Etiology, coming to the etiology, about 25 to 60% of the cases are unexplained. Identifiable causes can be attributed to maternal conditions, fetal conditions, and placental conditions. Coming to the fetal causes, which contribute to about 25 to 40% of the intrauterine fetal death, the commonest being chromosomal anomalies, birth defects, non-immune hydrops, infections like TORCH, toxoplasmosis, rubella, cytomegalovirus, and herpes. So these are all some of the conditions of trisomy 13. Here we get trisomy 18, Turner syndrome, rocker bottom foot. Coming to the placental causes, it could attribute to 25 to 35% of the intrauterine fetal death. The causes being abruptio placenta, any umbilical cord accidents, placental insufficiency, intrapartum asphyxia, placenta previa, twin-to-twin transfusion syndrome, and chorioamnionitis. So these are all some of the example of calcification, hemorrhage in the placenta. We see a true knot here, and this shows vasa previa. Coming to the maternal cause, which could be 5 to 10%, there are humpty number of causes causing intrauterine fetal death. One could be antiphospholipid antibody, diabetes, hypertension, any trauma, abnormal labor, sepsis, uterine rupture, postpartum pregnancy, drugs, thrombophilia, cyanotic heart disease in the mother, epilepsy, severe anemia. Unexplained contributes to 25 to 35%. This is a case of rupture uterus. We see a broad ligament hematoma here. These are all some of the examples of toxoplasmosis baby, rubella, and cytomegalovirus. We see calcification in the brain. Coming to, there are a variety of classification of intrauterine fetal death depending on the cause. So the commonest types being, we classify according to different classification: Wigglesworth classification, Aberdeen classification, Recode classification, and fetal neonatal classification. This Recode is nothing but relevant condition at death. So advantages of this system is it reduces the proportion of stillbirths or IUD currently categorized as unexplained. We want to know the cause of the intrauterine fetal death. So in recode category, we classify till group A to group I. Group A being fetus cause, group B is umbilical cord, group C is placenta, group D amniotic fluid, group E is uterus, group F is mother, group G intrapartum, group H trauma, group I is unclassified. So group A, coming to the group A, the causes be attributed to the fetus. It could be lethal congenital anomaly, infection could be acute or chronic, non-immune hydrops, isoimmunization, fetal-maternal hemorrhage, growth restriction. Coming to the group B, which attributes to umbilical cord, it could be umbilical cord prolapse, constricting loop or not, velamentous insertion of umbilical cord, and other causes. Coming to the group C, attributed to the placenta, we have abruptio placenta, placenta previa, vasa previa, and other placental insufficiency and other causes. Coming to group D, which is attributed to amniotic fluid, it could be chorioamnionitis, oligohydramnios, or polyhydramnios, or any other causes. Group E is contributed to uterus. It could be rupture, uterine anomalies, or other causes. Group F is attributed to the mother. It could be diabetes, thyroid, essential hypertension, any hypertensive disease in pregnancy, lupus, and antiphospholipid syndrome, cholestasis, drug misuse, and other causes. Group G is intrapartum. It doesn't come under IUD. It comes under stillbirth. It could be intrapartum asphyxia or birth trauma. Group H is trauma. It could be external or iatrogenic trauma. Group I is unclassified. So in this, we attribute no relevant condition identified and no information available. This is how we classify the according to the causes. Coming to the extended Wigglesworth classification, we have category 1 to 5. In category 1, it could be congenital defect or malformation. It could be lethal or severe. Only lethal or potentially lethal congenital malformation are included in category 1. Serious biochemical abnormalities like Tay-Sachs disease, any known single gene defects. Category 2 is attributed to unexplained antepartum fetal death. Most late pregnancy fetal losses could be coded here. This, where a live-born baby dies due to problems during the antenatal period, it could code as other specific causes in category 6. So coming to the category 3, it could be death from intrapartum asphyxia, anoxia, or trauma. So we are not going into detail about this because it comes under stillbirth. Category 4, it could be immaturity. This applies to live births only. So this also doesn't come under IUD. Category 5, it could attribute to infection. It could cause intrauterine fetal death, maternal infection with group B streptococci, rubella, parvovirus, syphilis, and baby dying with any overwhelming sepsis. Category 6 is other specific causes. Use this if there is a specific recognizable fetal, neonatal, pediatric condition which are not covered under earlier categories. Examples include fetal conditions like twin-to-twin transfusion and hydrops fetalis. Neonatal conditions, it could be pulmonary hemorrhage, pulmonary hypoplasia, persistent transitional circulation, blood loss associated with trauma. Example, vasa previa. And pediatric condition could be malignancy or acute abdominal catastrophe. Category 7, we have accident or non-intrapartum trauma. Confirmed non-accidental injury should be coded in category 7. And category 8 is sudden infant death, which doesn't come under IUD. Category 9 is unclassifiable to be used as a last resort. So these categories are advocated to promote a uniform classification and to identify the cause of the intrauterine fetal death rather than explaining it to be an unexplained fetal death. Coming to another type of fetal death, which is
Aditi? Yeah, madam has left, I guess.
I guess she has some network issues.
Wait, let me call once or wait for 2 minutes for the madam to join.
Okay, sir.
Yeah, madam is joining. Some net issues is there. Madam is joining.
Okay.
Good evening. Hello. Sorry,
Yeah, ma'am. Yes, ma'am. Yes, ma'am.
sorry about the interruption. I got a poor internet connection. Sorry, sir. Sorry.
Sure, sure. No problem.
When I shall I represent then, sir?
No, ma'am. We have gone up to that seventh stage.
Classification.
Yeah, stages of.
Wow. Okay. Okay. Fine. 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 I'm extremely sorry.
No issues, ma'am. It happens, ma'am.
This I have finished. No, I thought I was like I was just presenting. This I have finished. No, sir.
Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
Extended because with yeah.
Up to category 7 we are completed.
Okay. Thank you.
Okay.
I'm sorry, really sorry. This is extended Bigglesworth classification. We have sudden category 8, we have sudden infant death, which causes unknown. This comes under like a stillbirth, doesn't come under IUD. Category 9 is unclassifiable to be used as a last resort. We have another classification named as Nordic Baltic classification. In this, we have 5 variables. One is lethal malformation, time to death in relation to delivery, birth weight, growth retardation, gestational age, and an Apgar score. Coming to the Aberdeen classification, we have 2 types of classification. One is obstetric and another is a fetal and neonatal classification. We have different codes for different category of diseases. So we are going to explain the cause of the intrauterine fetal death so that we can prevent in future pregnancy. Coming to the categories, we have category 1 and 2 due to congenital anomaly. It could be any structural or genetic defect incompatible with life or potentially treatable but causing death. So code 1 is neural tube defect, code 2 are other anomalies, and we have category 3 and 4 causing attributable to isoimmunization. So code 3 is due to Rh antigen, code 4 is due to other antigens. And we have code 5, 6 due to preeclampsia. It could be code 5 is without APH, antepartum hemorrhage. Code 6 is complicated by antepartum hemorrhage. And we have code 7 to 9 attributed to antepartum hemorrhage, 7 being with placenta previa, code 8 is with placental abruption, and code 9 is APH of uncertain origin. So we have category 10 to code 10 to 13 due to mechanical causes. Code 10 is cord prolapse or compression with vertex or face presentation. Code 11 is other vertex or face presentation, and code 12 is breech presentation. Code 13 is oblique or compound presentation or uterine malformation. And coming to the 14, 15, 16 category, we have maternal disorders, maternal hypertension, and other maternal diseases. Code 16 being maternal infection. Coming to categories, code 17 to 19, we have miscellaneous causes like neonatal infection, other neonatal disease, and specific fetal condition. And code 20, 21, 22, we have 20 equal, we weigh the fetus equal or greater than 2.5 kg. If it is less than 2.5 kg, it is code 21, and code 22 is unclassifiable. This is obstetric classification. We have Aberdeen's fetal and neonatal classification 2. In this, we have congenital anomaly being 1 to 6 code. We have any structure or genetic defect incompatible with life. We have chromosomal defect, inborn errors of metabolism, neural tube defect, congenital heart defect, renal abnormality, and other malformation. And coming to the code 7 is isoimmunization. Code 8 to 11, we attribute to asphyxia before birth. It could be antepartum asphyxia, intrapartum asphyxia, birth trauma, and severe pulmonary immaturity. We have code 12 to 14, hyaline membrane disease. So it could be plain hyaline membrane disease or hyaline membrane disease with intraventricular hemorrhage in code 13. Code 14 is with infection. Code 15 and 16 contributes to intracranial hemorrhage with infarction. Code 17 to 20, we have infection, necrotizing colitis, enterocolitis, antepartum infection, intrapartum, and postpartum infection. Unclassifiable, code 22 is cord death, and code 23 is unattended delivery. This comes under stillbirth. So we have categorized different intrauterine fetal death attributable to the different causes causing the intrauterine fetal death. How we are going to diagnose and confirm this intrauterine fetal death? Because before opening it to a patient and their relatives, you have to reassure and you have to confirm it. So one is by history and examination. Patient might tell in some circumstances there is absence of fetal movements, there is retrogression of the positive breast changes, breast will become shrunken, gradual retrogression of the height of the uterus. It will not be attributed like compared to the gestational age. Uterine tone is diminished. Fetal movements are not felt during palpation, and fetal heart sounds will not be audible through the stethoscope or fetoscope. So diagnosis still can be confirmed by straight X-ray abdomen. You have Spalding sign. It usually appears 7 days after intrauterine fetal death. There will be hyperflexion of the spine, crowding of the rib shadow. You have Robert sign, appearance of gas shadow in the great vessels like aorta and IVC at 12 hours after IUD. And ultrasound is the gold standard. We can you can confirm and you can show to the patient and the relatives there is absent fetal movements, oligohydramnia, collapsed cranial bones, absence of fetal heart, and Spalding sign. So in a nutshell, how do you diagnose? By the history, examination, and the investigation. So history, there will be absence of fetal movements told by the patient, failure of uterine enlargement and the weight gain, and loss of signs or symptoms of the pregnancy. So you can examine and find out that the final height is less than the period of amenorrhea. There is no active fetal movement, no fetal heart sounds. Investigation, you have X-ray and an ultrasound. Ultrasound is commonly used You can show to the patient the absence of fetal heart and the absence of fetal movements. And X-ray, you can see spalding sign, hyperflexion of the spine, appearance of gas shadow in the chamber of the heart and great vessels, and the overcrowding of the ribs. So there are, you have to evaluate in detail to detect the cause. So maternal medical conditions like venous thromboembolism, diabetes, hypertension, thrombophilia, systemic lupus erythematosus, autoimmune disease, severe anemia, epilepsy, and heart disease. You have to ask past obstetric history of the patient, like gestational hypertension in the previous pregnancy with any adverse sequelae, plus any history of placental abruption, IUD in previous pregnancy, recurrent abortion, or baby with congenital anomaly or hereditary condition, and IUGR. So current pregnancy high risk being the maternal age, gestational age at fetal death, hypertension, diabetes mellitus, gestational diabetes, smoking, alcohol, any drug abuse, abdominal trauma, cholestasis, placental abruption, PROM or pre-labor rupture of membrane. Coming to the, I'm sorry about the spelling mistake, family history, you can ask for recurrent abortions, venous thromboembolism or any history of pulmonary embolism, congenital anomalies in the family, abnormal karyotype in the families, hereditary conditions or developmental delay. So how do you evaluate an IUD infants? One thing is you have to describe the infant, whether any external structural malformation, any skin staining, how about the degree of maceration, how the baby looks like, the dead fetus looks like, the color is pale or plethoroid. Umbilical cord, you have to check for prolapse, any entanglement in the neck, arms or legs, any hematoma or stricture, number of vessels in the umbilical cord, and the length of the cord. Amniotic fluid, you have to check meconium stain, liquor, and blood, and the volume of the amniotic fluid. These are all some of the fetuses of macerated fetus, mycognathia, conjoined twins. Coming to the examination of the placenta. First, you have to weigh the placenta, staining of the placenta, adherent clots, structural abnormality, any velamentous insertion of the placenta, and you have to check for the any edema or hydropic changes in the placenta. Membranes, you can check for any staining of meconium and any thickening in the membranes. This is a condition of vasa previa. Coming to the investigation. So how do you evaluate the maternal causes of intrauterine death? So do a complete blood count, blood group, and antibody screening for any hemorrhage, HbA1c and isoimmunization, and HbA1c you can check for diabetes, clear blood key test for isoimmunization, serological screening for torch infection, karyotyping of both parents for chromosomal anomalies, and you can do a HB electrophoresis for typing any anemia, antiplatelet antibodies, thrombophilia screening. This is common antithrombin 3 protein C and S deficiency, factor 4 Leiden mutation, factor 2 mutation, lupus anticoagulant, anticardiolipin antibody, and you have to evaluate for DIC. Fetal investigation, you can go in for fetal autopsy, karyotyping. Specimen can be taken from the cord blood, intracardiac blood, body fluids, skin and spleen, placental wedge, or amniotic fluid. You can do a fetography or radiography of the fetus. Coming to the placental investigation, in case of twins, you have to check for the chorionicity of the placenta, cord thrombosis or knots, infarcts, thrombosis and abruption, any vascular malformation. These are mostly external appearance. Any signs of infection, bacterial culture for E. coli, Listeria, and group B streptococcus. So having evaluated like you have classified the intrauterine fetal death, we have diagnosed and confirmed the intrauterine fetal death, and we have evaluated the mother, baby, and the placenta. Now coming to the pregnancy management, like how you are going to deal with the intrauterine death fetus mother. So you have to check whether it is single or multiple gestation, gestational age at the time of death of the fetus, and the parents' wish. So management, first, to the most difficult situation for any obstetrician is breaking out the bad news. Like because we have followed up the baby, the two in an unexplained fetal death, it is really disheartening for us to break out the bad news to the both the women and her family. So after like confirming them, even women might ask for a repeat ultrasound. They might not believe it when you tell. So they will be in such an emotional trauma. So if she asks for a second like opinion, you can very well offer her to another obstetrician, or you can like take her for next ultrasound, and you can show her for yourself and discuss with them the options of any expectant and active management. If the expected management is planned, avoid spontaneous onset of labor during the next 4 weeks. But during this 4 weeks, you have to reassure the woman that spontaneous labor can happen during the waiting period with no complication. But in some of the cases, there will be if the platelets is starting decreasing, if the fibrinogen levels are low, if the mother is showing signs of DIC, you have to intervene actively. But no women or family, once they know the news of intrauterine fetal death, nobody is willing to wait actually. So if induction of, when we come to active management, if induction of labor is planned, if the cervix is favorable, you can go in for oxytocin. If it is unfavorable, you have to ripen the cervix. But in an IUD fetus, they never ever rupture the membrane because it can cause infection. If spontaneous labor does not occur within 4 weeks, platelets are decreasing and the cervix is unfavorable, ripen the cervix. So complications of any intrauterine death fetus, be it 24 weeks, be it 26 weeks or a term, it gives psychological upset both to the patient and the family and the doctor. Infection, once the membrane rupture, infection especially by gas-forming organism like Clostridia welchi, it could lead to blood coagulation disorders. During labor, a patient can go in for uterine inertia and there will be postpartum hemorrhage. So morbid pathology. In intrauterine fetal death, actually a dead fetus undergoes aseptic destructive process that is called maceration. The epidermis is the first structure to undergo this process, whereby first the blistering and peeling of the skin occurs. It appears between 12 to 24 hours after death. The fetus becomes swollen and dusky, desiccated, gradually aseptic autolysis of the ligamentous structure and liquefaction of the brain matter and other viscera takes place. So the most important major role for an obstetrician is you have to empathize with the whole family. Death is a major stressful event for the children and the families. Traumatic event can bring serious psychological and social distress. So you have to deal with it properly. See, assess the emotional state of the parents, note the cultural beliefs and expectation, because anxiety and depression are a very common reaction to losses associated with any abortion or pregnancy losses. Personal expectations may affect response to the change. So determine as to what stage is the client is in grieving. You have to provide appropriate care. You can counsel, you can opt for psychologist counseling, and you have to review past life experience and previous losses. In case of recurrent pregnancy loss or any history of bad obstetric history, really it's very difficult to deal in this current situation. The role changes and coping skills, you have to know the strength and success. If they are following with you, you will know the patient and the family well. So it will be helpful in dealing with the current situation, and you can deal the problem very easily. Make time to listen to the client, encourage free expression of hopeless feelings and the desire to die. It is more helpful to allow these feelings to be expressed and dealt with than to deny or ignore them. Because some may be they might be violent, they might be crying, they might blame you even if it is not your fault. But you have to make them express, and you have to be patient at the time. And you have to assess the suicidal potential of the mother, because the postpartum surge in the hormones can cause suicidal tendency, though some mothers may not be able to accept the loss and attempt suicide in order to stop the feeling of guilt. And you should provide therapeutic touch as individually accepted. Convey your sense of concern and closeness to reduce the feeling of isolation and enhance the sense of self-worth. Identify the spiritual concerns. Be honest in answering questions and providing the information. And establish rapport with the client. You have to communicate them. You have to make them realize, and you can offer them investigation, and you can say this might be the cause. So you by serial monitoring, you can avoid in future pregnancy. So you have to give them the hope that support is needed for the grieving couple and the surrounding neighbors, relatives. So how do you prevent intrauterine fetal death? One thing is regular antenatal care. You have to screen out the at-risk patient to monitor carefully for the assessment of the fetal well-being and to terminate the pregnancy at the earliest evidence of fetal compromise. So we have the goal of antepartum fetal surveillance is to prevent the fetal death. So you have to assess the risk in pregnancies complicated by pre-existing maternal condition as well as those in which complication have developed. So modalities, we have varieties of modalities for antepartum fetal surveillance. We have fetal movement count, non-stress test, contraction stress test, biophysical profile, and ultrasound Doppler. You can do fetal movement assessment. You can give daily fetal movement count chart to the high-risk mother. You can ask them to mark. The easy and most attractive and simple method is count to 10. Actually, when they have done various studies in intrauterine fetal death or in a stillborn fetus, actually, they have compared the maternal perception of fetal movements, our non-stress test, ultrasound examination, and the clinical examination. In that, compared to all the four, the mother's perception of fetal movement is found to be a single indicator that can detect the intrauterine stress to the baby. And many of the times, it is the mother's perception is always true. So you can, like in a high risk mother, you can ask them to do the fetal movement count test from after 28 weeks itself, so that it is an inexpensive or non-invasive test. They can count to 10 in a 12 hours day, actually, in a day. Non-stress test, it is an indirect measurement of uteroplacental insufficiency. It is based on this, you can label the fetus as not acidotic or neurological depressed. It is a good indicator of normal fetal autonomic function. So this, I'm not going into detail. Biophysical profile, you can go for fetal breathing, fetal tone, somatic movements, Likert and non-stress test. Doppler flow, we can do an umbilical and MCA Doppler. So coming to the end of the session, intrauterine death is an unfortunate incident. It is an emotionally challenging for both parents and the doctors. It increases the medico-legal risk. It is an indicator of country's healthcare system. So our main aim should be to identify the at-risk mothers, and you have to surveil them properly. Antepartum fetal surveillance is a single indicator that can prevent many of the intrauterine fetal death, because this is actually obvious in the last 2 years. We have seen many of the intrauterine death. Most of them contributed to the COVID because it directly affects the placenta. There are many cases being reported: early oligohydramnios, placental calcification, COVID causing placental thrombosis leading to intrauterine fetal death. But many of the women were denied proper health care. Many at-risk mothers were lost for follow-up. That led to many maternal mortality and the intrauterine fetal death. So antepartum fetal surveillance is most important to prevent this intrauterine fetal death. Thank you very much for your patient listening. Any questions, I am ready to take. Thank you so much.
Thank you, ma'am. Thank you very much for that wonderful presentation, ma'am. Once again, a very good presentation, ma'am. Yes, ma'am. Intrauterine fetal death is a serious complication of pregnancy, and it affects the family and also in a psychological way, and it can also affects the woman's well-being. So thank you, ma'am. Thank you very much once again, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am.
Yes.
So, ma'am, meanwhile, ma'am, we have one of our product video to be displayed, ma'am.
Yeah, sure. I'll stop sharing.
Yeah. So we will start playing our.
Thanks. Yes.
Yes, ma'am. Once again. Ma'am, my video is not playing, ma'am. So no issues, ma'am.
Okay, sir. No issues. Sir.
Yeah, ma'am. So, ma'am, we have. I have one question from my side, ma'am.
Yeah, fine.
How long a dead fetus can stay in the womb, ma'am? Whether it can cause any the risk for the mothers? How long it can stay?
That is if it is without any complication, you can wait till 4 weeks, actually, ideally. according to the textbook, but many women will not choose to wait. But if you want to wait for spontaneous onset of labor, you have to follow up the patient like every 3 days or every week. You can do a coagulation profile. If she's not going in for any, do a complete hemogram also. If the platelets are not decreasing, if the coagulation profile is normal, you can very well wait for a spontaneous onset of labor. But if the fibrinogen level or any derangement in the platelet count, then you have to intervene earlier. Or else if there is no fever or no derangements in the fibrinogen level or platelet, you can wait actually till 4 weeks. If it is not expelled after 4 weeks, you have to like actively intervene.
Okay, ma'am. Ma'am, what to say? What are the causes for fetal dismissal after 39 weeks, ma'am?
After 39 weeks.
Yes,
After
ma'am.
39, late fetal pregnancy losses mostly could be any antepartum hemorrhage, but 20 to 25% we have unexplained fetal death. I don't know. I have like encountered like some two of my intrauterine fetal death in COVID times. Last February we had a very precious pregnancy of an elderly woman, but there are no complication. The growth of the fetus is good. Liker is normal. Patient didn't have any complication. The previous day, within 24 hours, I have checked the non-stress test. Fetal movement was normal. Morning, mild labor has set in, but patient has not come. When she came at 3 o'clock, like 9 o'clock, labor pain started. She came at 3 o'clock, like the baby was IUD. It was a 3 kg male fetus, well grown, and liker was nice, but it was a grade 3 meconium fetus. Could be like a tight, it is cord entanglement was there. One thing is like what caused the asphyxia, whether any trauma, the cord tightening around the cord entanglement and placental abruptions are most common cause of intrauterine fetal death after 39 weeks. And oligohydramnios too. But many times it could be unexplained.
Okay, ma'am. Ma'am, we have one question, ma'am. How do you confirm fetal demise? Can fetal heartbeat stop and start again? Any chances,
No,
ma'am?
definitely not.
Okay.
You can have any deceleration. So when we do a CTG, there will be deceleration, but it doesn't stop and come back. So always the gold standard is ultrasonography. So ultrasound, previously when when we are not in the era of an ultrasound, they usually do X-ray. So they check for crowding of the ribs and appearance of gas shadow in the large vessels. But once ultrasound has come, like you can check and recheck with an ultrasound, you can demonstrate the absence of fetal movements and fetal heart rate.
Okay, ma'am. Ma'am, what is the exact difference between the stillbirth and fetal death, ma'am?
Stillbirth is when the labor has started and baby has died during the process of labor. Like the patient has, the baby was alive till the labor has started.
Okay.
During the course of labor, if the baby dies, that is called stillbirth. It could be fresh or macerated. Fresh is less than 12 hours and macerated is like after 12 hours. Intrauterine fetal death is before the onset of the labor, after 500 grams and after 24 weeks, if the baby has died, then it is termed as intrauterine fetal death.
Okay, ma'am. Ma'am, can a baby survive stillbirth, ma'am?
No, stillbirth is stillbirth. It's dead
Okay.
mom.
Okay, ma'am.
Severe birth asphyxia, either if it is birth asphyxia but the baby is live, it can survive. If a baby on ventilator, baby on dopamine or something. But once stillbirth is a term for dead fetus only.
Okay, ma'am. So, ma'am, there are no other questions, ma'am. Ma'am, let me play the video, ma'am. Now it is available.
Yeah, sure.
Yeah,
Okay,
ma'am.
sir.
Yes, ma'am. Thank you, ma'am. Thank you very much for your time, ma'am. I would also like to thank our audience for their active participation, ma'am. I would like to thank my our Shield Healthcare team for making this webinar possible, ma'am. Thank you, ma'am. Thank you very much, ma'am.
Thank you so much. Thank you once again, Shield Connect, for giving me this opportunity, and thank you all for your patient listening.
Thank you, ma'am. Thank you.
Thank you.
I'm ending the webinar now.
Yes, sir.